Right. Now we'll be talking about, once we have done with the physiology of bilirubin handling, now we'll talk about that under what circumstances hyperbilirubinemia develops, which may eventually become a cause of jaundice. As you know, that normal bilirubin levels are considered 0.2 to 1.2 milligrams per dl. This is total plasma bilirubin. Total plasma bilirubin. Of course, this total plasma bilirubin should be divided into two parts, that is unconjugated bilirubin and conjugated bilirubin, right? So normally bilirubin level is this much. Due to any reason, if bilirubin level in the blood start going up, right, we say patient is developing hyperbilirubinemia. But when hyperbilirubinemia is sufficient enough to impart the yellowish coloration to your skin and mucous membrane and sclera and interstitial fluids or tissues, we say patient is jaundiced. Is that right? Now, whenever a patient comes with jaundice, of course the patient will have total bilirubin very high. But as a good doctor, you must determine that the major component of high total bilirubin is unconjugated bilirubin or conjugated bilirubin. In some patients with jaundice, the dominant component of excessive bilirubin is unconjugated. In other patients, the dominant component of excessive bilirubin is conjugated bilirubin. So it means that whenever you have a patient with jaundice, you have to think in the term of that patient is having unconjugated hyperbilirubinemia or patient is having conjugated hyperbilirubinemia dominantly. Now, let's talk about why hyperbilirubinemia develops and what are the causes which lead to unconjugated hyperbilirubinemia and what are the causes which lead to conjugated hyperbilirubinemia. We start from this side. One mechanism may be that there is excessive release of unconjugated bilirubin to circulation. Due to any reason, if your body starts producing excessive amount of unconjugated bilirubin to circulation, is that right? It's quite possible that the total bilirubin is released in such a rapid rate that liver cannot handle that well. And then unconjugated bilirubin start damming up into blood. This is one mechanism. Second mechanism is that bilirubin production is normal, but there is interference or problem in the bilirubin uptake. Mechanism number 2. Mechanism number 3 may be the bilirubin production is normal, bilirubin uptake by the hepatocyte is normal. Problem is with, yes, conjugation. That bilirubin, once it is taken up, it is not conjugated properly. Now, the group of patients will have problem either at level number 1, that is excessive bilirubin production, or problem number 2, poor hepatic uptake of the bilirubin, or problem at level number 3, that poor conjugation. These three groups of patients tend to develop unconjugated hyperbilirubinemia, right? Then after that, if someone has a problem beyond or distal to this point, for example, a person who is developing normal levels of bilirubin daily, producing normal level of bilirubin, hepatic uptake of the bilirubin is almost normal, conjugation is also normal. So it means whatever bilirubin is entering into hepatocyte, it is in a normal fashion, it is conjugated with glucuronic acid. Sometimes with bilirubin molecule we bind with one glucuronic acid, sometimes we bind with one bilirubin molecule to glucuronic acid. So it means liver is responsible to produce monoglucuronides and diglucuronides of bilirubin normally, right? After that, if person has problem at level number 4, what is the level number 4? Problem is with the active transport of bilirubin and other substances from the hepatocyte to the biliary canalicular system. It means dysfunction is on which side of the hepatic membrane? Hepatocyte membrane? Canalicular face of the hepatocyte membrane, right? Now, in mechanism number 4, bilirubin is getting conjugated but not getting to the biliary system. So it will spill back to circulation. So it will become what kind of hyperbilirubinemia? Conjugated hyperbilirubinemia. Then another cause of conjugated hyperbilirubinemia may be, intrahepatic obstruction to the outflow. And then there may be, extrahepatic obstruction to the bile outflow. Now, cause number 4, 5, and 6. They will produce what kind of hyperbilirubinemia? Conjugated hyperbilirubinemia. So first you should be able to determine in your patient, is really their jaundice is there or not. It means total bilirubin should be high. And right? Once you know there is jaundice or you know there is hyperbilirubinemia, the next step is to determine, is it unconjugated hyperbilirubinemia dominantly or is it conjugated hyperbilirubinemia dominantly. If it is unconjugated hyperbilirubinemia, then problem is at level number 1 or 2 or 3. It means either patient is producing excessive amount of bilirubin, or there is reduced hepatocyte uptake of the bilirubin, or there is reduced conjugation by the hepatocyte. And if patient has conjugated hyperbilirubinemia, then causes may be either problem is with the hepatocyte to transfer the bilirubin from interior of hepatocyte to the biliary canalicular system. A problem is there is biliary canalicular system within the liver is dysfunctional, intrahepatic, yes, obstruction or cholestasis, and there is some other outflow obstruction outside the liver, which may be in the right and left hepatic duct, or it may be in the common bile duct, or it may be at inflow of water, right? These are called extrahepatic bile outflow obstructions. Is that right? All of these mechanisms 4, 5, and 6, they will lead to conjugated hyperbilirubinemia. Now, let's start working upon our patient. Let's suppose you are in charge of the jaundice clinic, and patients are coming over there. Right? So, diagnosis of jaundice is not enough. If you are making the diagnosis and the patient is having jaundice, it is no diagnosis in fact, because you have to look for the cause always. Different patients may have jaundice due to different reasons which need to be managed in a different way. So jaundice is no diagnosis. Right? A good doctor will always look beyond that. Is there jaundice or not? If jaundice is there, what type of hyperbilirubinemia is there or not? What is the underlying mechanism and cause of that, and how to manage that? Now we'll talk one by one. Let's start with the mechanism number 1. The patients in which there is excessive production of bilirubin. So first of all, we'll talk about what could be the causes of excessive production of bilirubin. Yes, please. With patient who come into group number 1, and patient who are coming to the group number 1 are those patients who are having excessive production of bilirubin in their body. Now we have to think over why some people may have excessive production of bilirubin, right? Can you tell me any reason? Yes. Hemolysis. Do you think hemolysis will always produce excessive bilirubin? Answer is no. Because daily we have physiological hemolysis. You know, normally RBCs after about 120 days undergo physiological hemolysis. They are taken up by the macrophages, and these RBCs are rapidly destroyed within the macrophages. It means that hemolysis is within the circulation or within the cells? Within the cells. So that physiological hemolysis which occur within the cells, we call it extravascular hemolysis, because it is not within the vessels, it is outside the vessels into cells, macrophages. Right? So number 1 thing is that hemolysis occurs physiologically. Right? So, and we don't develop jaundice with that usually. So, then my question is that what are the conditions in which there is excessive production of bilirubin? You will say excessive hemolysis. Answer is not hemolysis, answer is excessive hemolysis. All hemolytic conditions, right, which break down RBCs excessively, and they produce so much bilirubin which liver cannot handle, then what will happen? What will happen? Unconjugated bilirubin level will go up into blood. Is that right? Now, remember here, if the cause of unconjugated hyperbilirubinemia is just excessive production, usually bilirubin level in the blood does not go more than 5 to 6 milligram per day. Again, let me tell you. If you have a problem due to which you are producing excessive bilirubin, whatever excessive bilirubin you produce, if your liver is functional, liver is capable of handling extra bilirubin, that it won't allow, yes, it won't allow unconjugated bilirubin to dam up into blood more than 5 to 6 milligram per dl. What does it really mean? It means if a patient comes who has unconjugated hyperbilirubinemia and his level is 10 milligram, it means problem is not with excessive production, probably problem is also with the uptake or conjugation. This is a mixed problem. Am I clear to you? Is it clear? Now, we were talking about what are the conditions in which there is excessive production of bilirubin. Of course, when there is excessive hemolysis. Now, excessive hemolysis may be sudden, severe excessive hemolysis. Number one in hemolytic anemias. Hemolytic anemias, where breakdown of RBCs will be very rapid and bone marrow is trying to compensate, but it cannot compensate, so hemoglobin levels start going down into blood. Number two, absorption of large hematomas. Absorption of large hematomas. If you have a large bleeding within the body and RBC is ruptured within the body, for example, you may have intraperitoneal hemorrhage, or in the gynae there are some reason, gynae ob, that there may be large hematoma formed, or then later on. Yeah, very good, very right. Ectopic pregnancy, or if person survives, right, then patient will develop jaundice, otherwise not. Right? If there's ruptured ectopic pregnancy or there's ovarian cyst or intra-abdominal hemorrhage, right, what really happens that if patient survives the acute collapse, you have been there and managing it well, then what really happens? A lot of RBCs which are present in the body, they rupture rapidly. A lot of macrophages go over there and try to convert that hemoglobin into bilirubin. And so much unconjugated bilirubin may flood into your circulatory system that liver cannot deal with it that efficiently, and that may translate into unconjugated hyperbilirubinemia. Then of course we can talk about abruptio placenta, which has, which one? Revealed hemorrhage is responsible for jaundice later on, or concealed hemorrhage? Concealed, of course. In the abruptio placenta, when placental attachment partially abrupts from the uterine attachment, and some hematoma may be having concealed blood collection between the placenta and the uterine wall, or even RBCs infiltrate into myometrium, which make it board-like rigidity and painful, right? So that RBCs will also absorb, and later on they may increase the load of bilirubin to the liver. And if a lady is unable to handle that excessive amount of, lady's liver is unable to handle the excessive amount of bilirubin, she may develop unconjugated hyperbilirubinemia. So I'm talking about that different type of hemolytic anemias or absorption of large amount of hemolysis, hematomas, that may lead to transient unconjugated hyperbilirubinemia. Sometimes that may produce mild jaundice. Then any other condition? Yeah. Physiological hemolysis occur at two stages of erythropoiesis. Who will tell me what? Some hemolysis occur during the erythropoiesis. You know, when ladies are cooking things in the kitchen, there are some intra-kitchen losses which never reported on the dining table. Is that right? In the same way, when bone marrow is cooking the RBCs, intra-bone marrow losses of RBCs occur. That is called which hemolysis? Yes. Okay, she has given a big statement, physiological hemolysis occurring during erythropoiesis. That is about 10 to 15% of normal erythropoietic process. Is that right? And in some diseases, this is one hemolysis, physiological. Secondly, when RBCs jump into circulation, they will complete their circulatory time and then they undergo terminal hemolysis. So there can be hemolysis during the erythropoiesis and hemolysis after the RBCs have completed their circulatory time. Both can be physiological. Now, in some conditions, intramedullary hemolysis, we call that intramedullary hemolysis. Physiologically, intramedullary hemolysis is 10 to 15 to 20%, 10 to 20%, right? It means for every 5 RBCs intact, 1 RBC is destroyed before it appears into circulation, right? Of course, those RBCs are also taken up by macrophages, and then what happens? They are also responsible to add to the unconjugated bilirubin pool of the body. Is that right? In some conditions, intramedullary hemolysis become very excessive. For example, in some conditions, 80% of the RBCs which are being produced during the erythropoietic process are destroyed within the bone marrow before they appear into circulation. This is excessive. Can you tell me some conditions like that? You understand my question? It's in English. I'm talking about that sometimes erythropoiesis is going on very rapidly in bone marrow. And due to some dysfunction, intra-bone marrow losses become percentage-wise very heavy, that for every RBC, one RBC spilled into circulation, 4 may be destroyed within the bone marrow during the erythropoietic process. We call it that there is pathologically excessive what? Intramedullary hemolysis. So what could be the reason for that? Please tell me. Any
Producing abnormal type of RBC.
Any severe condition in which bone marrow is doing its best, it has accelerated erythropoiesis, especially in pernicious anemia, B12 deficiency, and then in every B12 deficiency is considered pernicious anemia or not? But how do you define pernicious anemia?
Pernicious anemia is the absence of the intrinsic factor.
Okay, you remove my stomach. For example, you become angry with me, you remove my stomach and throw it to some birds, and you connect my esophagus with the duodenum. Do you think I will develop pernicious anemia? Answer is no. But I won't have an intrinsic factor. So this is not enough to say that deficiency of intrinsic factor is just pernicious anemia. A very good doctor, you have given an answer from a good doctor, but a very good doctor will say pernicious anemia is megaloblastic macrocytic anemia produced due to deficiency of intrinsic factor, which must be due to autoimmune process directed against parietal cell and intrinsic factor itself. Look, whenever you have deficiency of intrinsic factor, if deficiency is due to autoimmune process, then it is pernicious anemia, otherwise it is not. Is it clear? So post-gastrectomy, right, intrinsic factor deficiency should not be labeled as pernicious anemia. Anyway, if someone has pernicious anemia or folic acid deficiency anemia and bone marrow is really accelerating its erythropoiesis and a lot of abnormal RBCs are made, and before those RBCs spill into circulation, they are destroyed within the intramedullary cavities, where that may produce heavy load of unconjugated bilirubin to the circulation. Liver cannot handle that, and that may end up into unconjugated hyperbilirubinemia. So we can say that excessive, yes, what is this? Excessive intramedullary hemolysis. So all these conditions have a tendency to load the body with excessive amount of bilirubin, and if liver cannot handle all that bilirubin, unconjugated hyperbilirubinemia will be there. Now, with all these things, there's some other features as well. This is called prehepatic, you can say prehepatic jaundice, because the problem of the jaundice is not due to hepatobiliary dysfunction. Problem is that normal hepatobiliary system is overloaded with the unconjugated bilirubin. Now, how you really know that, let's suppose a patient comes with jaundice, how you really know that problem is prehepatic? Let's talk about the parameters related with that. Okay, this is the investigations or some important pointers, right? If a patient has, okay, I will make these scenarios later, right? We'll talk about the clinical scenarios later in the lecture. I will continue first with the basic concepts, causes and concepts. Then we'll go to the clinical scenarios and laboratory interpretations of abnormal results of liver function test and hematological and serological results. Now, we have talked about this. Here you have to remember excessive hemolysis. Then if there is excessive displacement from the bilirubin here, you have to remember at least one drug. What is that? Sulfonamides. Then I told you there are some mechanisms in which uptake of bilirubin by the liver is reduced. For example, I told you rifampicin, right? After that, we come to the conditions in which problem is with the conjugation. That conjugating power of liver is reduced. It means that there is poor conjugating power of the liver. Now, when we talk about that impaired bilirubin conjugation, at the top must be physiological jaundice of newborn. Right? In physiological jaundice of newborn, the one of the major reason is that hepatobiliary system is immature. Hepatocytes have not yet expressed the genes related with formation of glucuronide transferase with full power. So baby's liver, newborn's liver has, you can say hepatocytes have an undersupply of glucuronide transferase. Number one problem. Secondly, when baby is born, fetal hemoglobin is breaking down. So slightly extra load of unconjugated bilirubin to the liver and significant impairment in the conjugating power of the newborn's liver. So both of these are combined together to produce slight elevation in unconjugated bilirubin in the blood. So newborns usually develop what kind of hyperbilirubinemia? Unconjugated hyperbilirubinemia. They produce unconjugated hyperbilirubinemia. Right? Okay. So this is one cause that there's problem with the conjugation. There's decreased enzyme activity in the. Secondly, not only their hepatobiliary, both systems are disturbed. In newborn, not only they poorly conjugate the bilirubin, rather they have one more problem, that whatever they conjugate, they do not effectively throw here. Right? But main problem is poor conjugation. Is that right? After that we come to another, there is another term used, breast milk jaundice. What is breast milk jaundice? What is breast milk jaundice? I think someone put music with this information. So, yes. What is breast milk jaundice? No one knows about it. You should know it, isn't it? Okay, let me tell you. That actually in the breast milk there are some enzymes which break down the conjugation between the bilirubin and glucuronic acid. So we call them breast milk D-glucuronidases or simply glucuronidases. Now, normally, physiologically, in the breast milk, there is significant amount of glucuronidases enzyme. Now, if baby is heavily fed through breast and not on other sources, what will happen? That breast milk, when it will go to the GIT, in the baby's GIT, whatever conjugated bilirubin is coming, it will deconjugate that. Whatever conjugated bilirubin is coming, breast milk enzymes will break down that conjugation process. Is that right? And what will happen? Unconjugated bilirubin will be again taken up into circulation, and that may become unconjugated hyperbilirubinemia. Is that right? So this is one problem more, right? We call it breast milk jaundice, right? Then we come to some more causes. There are some syndromes. Now we are entering into the valley of syndromes. Okay. This is which enzyme? Please name it. Glucuronide transferase. Of course, this is a protein. So proteins are synthesized by the expression of genes. Now, if we do something wrong with the genes concerned with the synthesis of this enzyme, it is quite possible synthesis of this enzyme become impaired. Is that right? Now, let's talk about inherited disorder in which you inherit the defective genes. Where you are inheriting defective genes which are supposed to synthesize glucuronide transferase. Now, it's very easy to talk about this, that in these hereditary conditions, there may be mild deficiency of glucuronide transferase, or there may be moderate deficiency of glucuronide transferase, or there may be severe deficiency of glucuronide transferase. Of course, there are how many genes which are making this enzyme? At least there should be how many genes to make this enzyme? You never counted it. Too busy in your life. Yes. Have you been counting it? It's too easy. One gene should come from mother and another should come from father. So minimum for everything you should have two genes. Except Y chromosome which only come from the father. Right? Most of the genes are present as double copy. One maternal and another paternal. Is that right? So it means that problem may be with the genes, right? With one gene or both genes. And problem may be producing mild deficiency of this enzyme activity or moderate deficiency of this enzyme activity or severe deficiency of this enzyme activity. Is that right? Now, in about 2 to 7% of the population, there's mild deficiency of this enzyme activity. In 2 to 7% of the population, there is mild deficiency of this enzyme. So in these people, there is a tendency to keep all the time slightly high level of what? Unconjugated bilirubin. But usually it is not enough to produce jaundice. But if these people undergo some sort of stress, they may undergo fasting, especially more than 24 hours, or they undergo dehydration, or they undergo excessive physical activity. Under all these circumstances, these people tend to develop mild jaundice due to unconjugated hyperbilirubinemia. And in these patients, all other things are normal in their body. Now here I want to highlight one thing. You know, before I really go to the function of this enzyme, I will go to discuss about the height of the human beings. You know, the people, for example, if we say that human female, what is the average height of human female? Yeah?
5'4".
I think you have been meeting with, including the Western and Eastern both world, it must be 5?
1.
Okay. I think it's around 5'4" or 5'3", depends on what kind of female you are coming across. Okay, we keep with this young man's idea that average height is, most of the females have height around 5'4". Is that right? Their number is very high, such females. Then females who have a height of 5'2", they are less. Females with the 5'1" are less. Having only 5 is less. And of course, having 4 is extremely less. And of course, there are females which are taller than the average female. So the females who are 5'6", they are also less in number. There's a percentage. And females which are 5'8" are less. And thank God, females with 5'10" are very less. And females with 6 are, alhamdulillah, very rare. Now what we really find, that this is normal characteristics. Do you think, if we say that normally female has a height of 5, on average 5'4", suppose, if you come across a female which has a height of 5, do you think she's abnormal? Or if you come across a female which is 5'8", is it abnormal? No. We say this character of height is distributed in a Gaussian fashion, Gaussian curve, bell-shaped curve in human population. This concept is clear? And these females in the very beginning, too short and too, not long, actually tall, females just present what? Ends of the Gaussian curve. Is that right? Same is true about many other functions, including your efficiency of glucuronide transferase. There are a lot of people who have average activity of glucuronide transferase. Some have really very excessive activity of glucuronide transferase. Some people have relatively less power of glucuronide transferase. So people who come at the end of, if this curve is for the glucuronide transferase activity, right, then the people who come to this end of the curve, they are 2 to 7%. These are not significantly diseased people. Rather, they are not diseased people. These people have some mutations in their gene, which are especially mutations in the promoter boxes. Their gene does not express fully. In 2 to 7% of the population, the gene does not express, glucuronide transferase genes do not express fully, but whatever messenger RNA they make, they're normal. Right? So they do make glucuronide transferase enzyme, but in slightly less concentration in their hepatocytes. Due to that reason, whenever there's extra challenge to the liver with unconjugated bilirubin, they cannot handle and they develop unconjugated hyperbilirubinemia. Now, this population is extremely important to diagnose. You know why? Extremely important. Because number one, their number is very high, 2 to 7% or on average 5% of population. Number two, these people develop mild jaundice many times in their lifetime. They all the time, they are keeping unconjugated hyperbilirubinemia, and as I told you, when these people have stress, they may tend to develop mild jaundice. But the liver enzymes are normal. There are no features of excessive hemolysis. Liver enzymes are normal. There are no features of outflow obstruction, biliary obstruction. Right? Why they are so important? Because you diagnose them and tell them that this hereditary problem is not dangerous, so that they don't undergo undue, excessive, repeated investigations for their jaundice. It is just the end of the normal Gaussian curve. Is that right? So whatever unconjugated bilirubin goes up in their blood, that usually does not produce any disease problem to them. That does not produce any disease. The only disease is created by the doctors which do not diagnose this condition, and even they don't know this condition, so they keep on sending them, okay, this time I could not find anything, next time when you develop this thing, please come to me again. So I want to know, what is the name of this condition? Yes, Dr. Antal, Dr. Tanzila. At least we should know the name of this condition, isn't it? This is called Gilbert syndrome. Have you heard of Gilbert syndrome? That is that thing. Gilbert syndrome. So, what is this? Yes, please. This mild problem is? Yeah? Gilbert syndrome. So today onward, what is Gilbert syndrome? Not a dangerous thing. Very common thing. To be diagnosed only to reassure the patient so that patient does not undergo repeated undue investigations. Is that right? These patients have, you can say, a lower end of normal range of enzymes. Enzyme is just too low, but not so low to produce dangerous pathologies. Is that right? Am I clear? Now we come to the problem who have moderate and severe deficiency. The people who have moderate or severe deficiency of these enzymes, they are labeled as Krigler-Najjar syndrome. Krigler-Najjar syndrome. Right? Now this Krigler-Najjar syndrome again is of two types. Yeah? Krigler-Najjar syndrome is again of two types. In one type of Krigler-Najjar syndrome, what really happens, that there is severe deficiency of what? Glucuronide transferase. And in other type, there is moderate deficiency of glucuronide transferase. Right? So what really happens, that this is, which is having a severe problem, this is called Krigler-Najjar type 1. And this which has moderate problem is called Krigler-Najjar type 2. Is that right? Again, let me repeat it. We have put Gilbert syndrome and Krigler-Najjar syndrome as the syndromes in which problem is with glucuronide transferase. If you really love someone, always pray. If problem has to be there, it should be Gilbert, not Krigler-Najjar. Because in Krigler there is very mild deficiency, so there is asymptomatic unconjugated hyperbilirubinemias, not a big deal. Problem really start when there is moderate deficiency. And moderate deficiency, it is autosomal dominant disorder in which there is significant reduction in what? Glucuronide transferase activity. And these babies develop very severe unconjugated hyperbilirubinemia. Of course, they have a higher risk of developing cardiac arrest. Right? How would you treat these patients? There are two things. Number one, how would you treat them? And number two, how do you cure them? Yes. How do you treat them? You give some drug which can induce the enzymes. Treatment is phenobarbital. You know, phenobarbital induces hepatic enzymes. It forces the genes to overexpress. Do you know that or not? So, we give these babies Krigler-Najjar 2 phenobarbital, which keep on forcing the hepatocytes to overexpress the genes, and glucuronide transferase should be more, so that bilirubin handling should be at least somewhat better. And if you really want to cure, you cannot cure it short of liver transplant. We don't have any other treatment. Right? Then we come to Krigler-Najjar 1. I don't know, it's really how bad condition. It's bad for mother actually, because baby never really suffers so much, because baby dies very early, sometimes in intrauterine death or just after the birth. In Krigler-Najjar 1, baby never sees first birthday. You know why? Krigler-Najjar 1. Because there's severe, very, very severe deficiency, or almost in some cases absence of glucuronide transferase activity. So unconjugated bilirubin becomes so high that it cannot be kept fused with, all of it fused with plasma protein. So all excessive bilirubin will flood into tissues, including central nervous system, and such a high toxic level of this substance will damage the central nervous system so much that it won't remain compatible with the life. Is that right? Talking about that unconjugated hyperbilirubinemia is either due to overproduction and overpresentation of the unconjugated bilirubin to the liver, or it is due to reduced uptake, or it is due to impaired conjugation. In impaired conjugation, we were talking about inherited disorders and acquired disorder. In inherited disorder, we talk about Gilbert syndrome, in which there is a mild impairment, very mild impairment, no consequences on the patient's life. Then there is moderate impairment in case of Crigler-Najjar syndrome type 2. And of course, Crigler-Najjar type 1, very, very severe deficiency or almost absence of right? Glucuronide transferase. And that will end up into very high levels of unconjugated bilirubin in infant or in the newborn, and almost all cases are fatal. Then we are talking about acquired causes of impaired glucuronization function by the hepatocytes. Here I would say all the mechanisms which produce inflammation of hepatocytes. Anything which produces hepatitis, that produces, of course, hepatocellular dysfunction. And when you have hepatitis or there is hepatocellular dysfunction, bilirubin handling will become impaired in two mechanisms. Why? When you have inflamed and dysfunctional cells, number one, they will conjugate poorly. Number two, these membranes will become defective in inflamed cells, and they will not secrete the conjugated bilirubin properly. Even inflamed cell will swell up, and when they will swell up, they will compress the biliary canaliculi, and there will be intrahepatic cholestasis. Let me repeat it again. That anything which produces hepatitis, it means that will lead to dysfunction and swelling of hepatocytes. And when hepatocytes are having impaired function, number one, they will have impaired conjugating function. Number two, they will have impaired secretory function to the bile side. Due to that reason, in hepatocellular injury or due to hepatitis, patient develops jaundice, in which not only unconjugated bilirubin goes up, but also bilirubin which is getting conjugated may not be able to clear or pass through biliary outflow system, so that will also spill back to circulation, and patient may develop conjugated hyperbilirubinemia as well. Right? So in a nutshell, we can say that in patients with hepatitis, right, there is hepatocellular dysfunction, and that will produce impaired conjugation function as well as impaired secretory functions. When both functions are impaired, that will lead to unconjugated hyperbilirubinemia as well as conjugated hyperbilirubinemia. Right? Now, what could be the causes of hepatitis? Okay. First of all, I want to know, how do you define hepatitis? Who will define hepatitis for me? Dr. Kashif. What is hepatitis? Don't give me a definition which no one knows in the world.
Simply stated is inflammation of the liver.
Okay. This is one way to say hepatitis is inflammation of the liver. Listen one thing. Attention please. For example, you take a liver biopsy. Of course, you damage few cells and they are inflamed. Is that right? Few cells are damaged and small amount of liver tissue is inflamed. Do you call hepatitis? What is the simple definition of hepatitis? Hepatitis is inflammation of liver characterized by spilling of inflammatory cells from portal tracts into liver parenchyma. Is that right? Will you remember that? Please write it down. What is hepatitis? In a simple term, hepatitis means inflammation. He is right. But when you are talking about histopathology, how we really know there is hepatitis or not? When a patient is suffering with hepatitis, actually from the portal tracts, inflammatory cells are spilling in big number to liver parenchyma. Right? So what is hepatitis? Inflammation of liver characterized by spilling of inflammatory cells, of course in acute hepatitis, neutrophil, and chronic hepatitis, lymphocytes, and acute viral also lymphocytes, right? Spillage of inflammatory cells from the portal triad to the liver parenchyma. Clear? Now, what are the causes of hepatitis? Now this is, let's suppose, This is liver lobule, and if it is injured by any mechanism, that will produce hepatitis. Right? So can you tell me some important causes of hepatitis? Yeah. Okay, viral hepatitis. We should divide it into infectious and non-infectious hepatitis. Hepatitis is infectious and non-infectious. So first of all, we should write here infectious hepatitis and hepatitis due to without infection, that is non-infectious hepatitis. Now, infectious hepatitis may be viral, is that right? And which virus you will tell me? Don't tell me just A, B, C, D, E. Tell me something more than that. Viral hepatitis. Hepatitis virus is actually hepatitis B virus. Right? Again B. What I'm talking about, look, when we say there is viral hepatitis, okay, viral hepatitis may be that some virus is damaging the liver. Some viruses predominantly involve the liver and other viruses involve the liver as well as many other tissues. The viruses which specifically involve the liver or more prominently involve the liver, they are called hepatotropic viruses. And the other viruses which may involve many organs, liver is only one of those organs, those viruses also produce hepatitis, but they are not called hepatotropic viruses. So when we talk about hepatitis, viral hepatitis, we should talk about viral hepatitis due to, yes, hepatotropic viruses and non-hepatotropic viruses. In hepatotropic viruses, of course, we specifically love to produce problem dominantly in the liver, hepatitis A, hepatitis B, hepatitis C, and delta or D, which produces problem when it is co-infected or superimposed on B infection. And then hepatitis E. We'll not go into detail of these viral hepatitis, but what I'm talking about, viral hepatitis may be due to hepatotropic viruses, which are A, B, C, delta, and E. Then there are some viruses which are not hepatotropic. Can you tell me a few viruses which are not hepatotropic but can produce hepatitis? It means they, of course, they do bind with in a very strict sense, they are also hepatotropic, but along with that, they also involve many other tissues, right? So they're not specifically hepatotropic. Of course, you must be able to tell me Epstein-Barr virus, right? You must be able to tell me yellow fever virus. You must be able to tell me cytomegalovirus. This is the minimum 3 you are supposed to know when you go for your international career, right? So viral hepatitis. There can be bacterial hepatitis also. Can you tell me some bacteria which can produce hepatitis? Of course, one of the spirochetes. Spirochetal or spirochetal. Bacteria are basically spring-shaped, coiled bacteria. Out of spirochete, right, which one produces hepatitis? I will give you a scenario. There is a person who is sewage worker and he has developed hepatitis with rashes and bleeding tendencies. What do you think? What could be wrong with him? There's something related with sewage worker. There are in the large sewerage pipes, there are rats or their wives, mouse and male, female, all of them. Some of them pass in their urine a special type of bacteria which is called, excellent, Leptospira ectohemorrhagica. Leptospira ectohemorrhagica. And this bacteria, when it enters in your body, not only it produces leptospiremia, it is spreading in the blood, but it also localizes in liver and produces severe hepatitis, right? And many other problems, right? Especially bleeding tendencies. And many other bacteria as well. So viral hepatitis, bacterial hepatitis. Can there be protozoal hepatitis? Can there be protozoal hepatitis? Can you tell me some name of the protozoa which can produce hepatitis? Yes. Amoeba can produce hepatitis. Right? When it is widespread in the liver, usually it produces a localized abscess. Any other? Toxoplasma gondii, that can produce hepatitis. Toxoplasma gondii also produces severe problem in the central nervous system of AIDS patient. From where the Toxoplasma gondii come? At least you should know cats. People who are cat lovers, or they raise the cats, or they keep the cats, they may get Toxoplasma gondii. Under what circumstances you should not keep the cats in your home, preferably?
Any autoimmune deficiency?
No, when the family, some female in the family is pregnant. Because in pregnant females, if they get Toxoplasma gondii from the cats, they can pass it transplacentally to the baby, and there's severe damage to the baby, right? So I think you must be knowing that, isn't it? You're working in gynae. What Toxoplasma gondii does to the baby? It is one of the torch infections, isn't it? It's the first one of the torch infection, right? It comes from the cats and many other pets also, but dominantly from the cats. What it is doing to the baby? You have no idea. But actually, when baby develops transplacental acquisition of the Toxoplasma, it produces ear problem. Ear development is defective, eyes development is defective, and cardiac development is defective, and many other combinations can occur as well, right? Anyway, let's come back. So we are talking about there can be viral, there can be bacterial, there can be protozoal hepatitis. Okay, let's come to the non-infectious causes of hepatitis. Can you tell me some known? First of all, toxins, chemical toxins. Can you tell me some chemical toxin which can produce severe hepatitis, even kill the person? Okay, very good. Alcohol is also, it should be considered chemical toxin when it is producing severe damage to your liver. Usually it is not classified as chemical toxin, but theoretically you are right, even though many alcohol lovers may not agree with you, right? So why don't you tell me something more dangerous and less loved? Carbon tetrachloride. Carbon tetrachloride is present in bleaching powders and other, and if you really get fumes of this, it will lead to hepatocellular failure as well as renal failure and very severe damage. Okay, don't that is related with the fungus, right? There's biological toxin, aflatoxin. I'm talking about chemical toxin. Okay, just in your honor, I will make here. Okay, alcohol can produce also hepatitis. Is that right? Alcohol can also produce hepatitis. Carbon tetrachloride is less common cause, but drastic cause. Alcohol is a common cause of hepatitis or chronic liver damage. And remember one thing, that in jaundice, when you are taking the history of alcohol intake, most of the people unknowingly understate their consumption. Is that right? Not only to their wives, but also to the doctors, right? Then toxins, alcohol, yes? Okay, why don't we forget here fungi? Fungi can also produce problems. Have you heard of Amanita phyllidus? This is a fungus. Mushroom, yes, mushroom. That can also produce problem, right? Then of course, alpha toxin or aflatoxin? Aflatoxin, that is also toxic to the liver. That's very good. And any other non-infectious drugs? There's so many drugs which produce hepatitis. So many drugs which may react with the liver substance and produce. Of course, you should not forget halothane, which is very notorious and less dangerous. But more dangerous is like paracetamol overdosage, right? That can produce severe hepatitis. And there's a long list. Yeah, any other cause of non-infectious hepatitis? Yeah? Autoimmune, yes. Autoimmune hepatitis. Autoimmune hepatitis is more common in males or females? I don't know. Females suffer with a lot of gynae problem as well as autoimmune diseases, but still they outlive the men. We have to sort out this mystery one day, right? Now, so toxins may be chemical toxins, or alcohol may be there, or drugs may be there, or autoimmunity may be there. What else? Yes. Tell me just one more cause of non-infectious hepatitis. Very important cause. Severe, yes. Fill in the blanks, please. Severe hypoperfusion to the liver. When there's prolonged severe hypoperfusion to the liver, prolonged ischemia of the liver, in shocked patients sometimes, right? What will happen? Many cells of the liver will become necrotic. And to eat up those necrotic cells and handle those necrotic cells, inflammatory cells will spill over into liver parenchyma. So, that may be responsible for hepatitis. Can you tell me some more graceful but rare causes of hepatitis? Why don't you tell me some metabolic disorders? Yeah, Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency. These are very graceful causes to mention, but less often seen. Of course, hemochromatosis is a bit more common. So, that can also produce metabolic disorders. Metabolic disorders. There's so many of them, but at least you know 3 of them. What are those 3? Wilson's disease. Especially in which you make a special type of ring, copper deposition ring in the, at the junction of sclera and the cornea at the limbus. That is called? No, that's the only thing my pronunciation is very right. Kaiser-Fleschner ring. Right? Kaiser-Fleschner ring. Right? You develop a brownish ring, and what type of visual problem it produces? Usually it does not. It is main importance is diagnostic. Kaiser-Fleschner ring. Wilson disease. Copper overloading condition in liver as well as basal ganglia. Right? That is why people develop motor dysfunction, extrapyramidal signs along with cirrhosis. Right? Okay. Wilson's disease, hemochromatosis. That also produces hepatitis and jaundice. And with that, of course, gray coloration of the skin. What is the common causes of death of hemochromatosis? No. What do you think? Iron is trying to go out of kidney? What are the important causes of death in patient with hemochromatosis? It is one of the most common inherited disorder in the Western world. So you must know that. One of the most common. Very common. At least tell me cirrhosis, we are talking about liver. Many patients with hemochromatosis go into repeated damage due to iron loading to the hepatocytes and cirrhosis occur. Any chronic inflammation of liver will lead to cirrhosis. So tell me, many patients die of complications of cirrhosis. Many patients die Another important cause of death is, yes please, in hemochromatosis patient is, we call this bronze diabetes also, isn't it?
Yes.
So, what should be done? Don't tell me bronze color of skin kill the patient.
Diabetes.
Yeah, it damages the, you can say, pancreas. And diabetes, if you don't manage, person may die of complications of diabetes. But more pathetic death comes due to hemosiderin getting deposited in myocardium. And that is the major cause of death. The only treatment for that problem is cardiac transplant. Right? So, anyway, what I was trying to tell you, anything which produces hepatitis has a capability to produce jaundice, and that hyperbilirubinemia, partially unconjugated and partially conjugated. Let's move forward. So we have discussed the causes of unconjugated hyperbilirubinemia, which may be either overproduction of bilirubin or displacement of bilirubin from the proteins by the drugs, or it may be reduced uptake, or there may be poor conjugation. Now let's come to the causes of what? We talk about the causes of conjugated hyperbilirubinemia, right? And in case of causes of conjugated hyperbilirubinemia, we can divide rather into 2 mechanisms. 4 mechanism is here. Intrahepatic outflow problem, intrahepatic cholestasis, you write it here 5. And this is extrahepatic cholestasis. 4 and 5 have made one group, right? The group in which there is impaired conjugation is going on. Either cell cannot push the conjugated material here, or conjugated material which is pushed over here, it cannot go out of liver. Is that right? So we say 4 and 5 causes previously have made them as intrahepatic cholestasis. And this was the 6th, which is now called 5th. This is extrahepatic cholestasis. Is that right? Now first we'll talk about the causes of intrahepatic cholestasis. That what's wrong with the liver, that once bilirubin is conjugated, either it cannot be properly drained through intrahepatic canalicular system, right? Now let's come to the causes of that. First of all, we'll talk about impaired canalicular transport of bilirubin, glucuronides. Here, these transporters are not working. What could be the causes of impaired function of these transporters?
Inflammation of hepatocytes.
This is one. Let's talk first inherited disorder and then acquired. As we reduce glucuronide transferase activity, we divide it into what? Inherited disorder and acquired. Now we are talking about that if intrahepatic cholestasis occur, bile or you can say bilirubin cannot be pushed through, then causes which are inherited and causes which are acquired, right? Inherited causes, one is Dubin-Johnson and other is Rotter, right? One is Dubin-Johnson, another is Rotter. Rotor syndrome. The good news is that both of them are innocent. Patient does develop conjugated hyperbilirubinemia, but not a big complication to his life. So Dubin-Johnson syndrome and Rotor syndrome, both of them have a problem that there is poor conjugated bilirubin transport from the cell to the biliary system, right? But what really happens that usually this conjugated hyperbilirubinemia does not have any other marker of injury, so usually it is not toxic to the patient, right? Of course. Now in this condition, Dubin-Johnson and Rotter syndrome, what is the real difference in them? These are two different conditions. Just tell me one point how they can be differentiated, of course, other than spellings. How do you differentiate them? Dubin-Johnson. Johnson was a white person or black person?
Black.
There was one very famous Johnson who was black. Why the Johnson was famous? Michael Johnson.
Michael Jordan.
Anyway, there are many, you can say, black-colored Johnsons. So you can remember that in case of Dubin-Johnson, liver becomes black. When you take the biopsy, liver is black because a lot of metabolites which were supposed to be secreted by the hepatocyte into biliary canaliculi, they accumulated within the liver. Especially metabolites of breakdown of what is retained in the hepatocyte which produces black color. Yes, please don't tell me conjugated bilirubin. Because conjugated bilirubin is poorly secreted in Dubin-Johnson as well as in Rotter. But Rotter liver is not black. Dubin-Johnson liver is black. What could be the reason? Because Dubin-Johnson has one more problem. Not only conjugated bilirubin cannot come out, rather plus there is another problem and another transport system which is supposed to secrete what? Metabolites of catecholamines, right? And when the metabolites of catecholamines are retained here, they imparted black staining. Is that right? Not melanin. Now, everything black is not due to melanin, right? Anyway, so let's come back. So I was talking about these are two innocent. So if you really want to know about three innocent, one is Gilbert with unconjugated hyperbilirubinemia and Dubin-Johnson and Rotter, conjugated hyperbilirubinemias. But in between is the Krigler in a jar, which is very, very bad, right? Type 2, you do survive, but very severe problem, or type 1, you simply don't survive. It's not compatible with life. Is that clear? Then we come to other causes, right? That is hepatocellular damage and toxicity. I told you hepatocellular damage should be classified as a cause of unconjugated hyperbilirubinemia as well as hepatocellular damage should be classified as a cause of conjugated hyperbilirubinemia. Now conjugated hyperbilirubinemia again can be caused by hepatitis. Hepatocellular damage means there is hepatitis. So no need to go into big discussion, again come up all these things. All types of hepatitis will produce some impairment in hepatocellular function, in conjugation, and some impairment in capability of hepatocyte to secrete the bilirubin, and some impairment in the drainage system. Am I right? What will be the causes again? Infectious hepatitis, which is viral, bacterial, protozoal, fungal, Or you will talk about non-infectious hepatitis. And non-infectious hepatitis may be due to alcohol, it may be due to chemical toxins, it may be due to drugs, it may be due to ischemic deficiency, it may be due to metabolic inherited disorders. Is that right? Or prolonged ischemia, whatever.